بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف خلق الله سيدنا محمد وعلى آله وصحبه ومن والاه. كل سنة وحضراتكم طيبين، وليلة جديدة من ليالي E.U.P وليالي المؤسسة المصرية لأطباء أطفال مصر. أنا معاكم دكتور بهاء الشيخ، استشاري طب الأطفال ورئيس المؤسسة المصرية لطب الأطفال والأطباء الأطفال. يا أهلا وسهلا بكم. والنهاردة معنا يوم جميل من ليالي الخبراء. معنا من اليمن أستاذ دكتور أحمد صلاح الدين من اليمن الشقيق. ودكتور أحمد، حضرتك معانا؟
معك.
يا أهلا وسهلا بحضرتك. دكتور أحمد دايركتور اوف بيدياتريك نيورولوجي ريزيدنسي بروجرام في الكينج سعود ميديكال سيتي الرياض. هيشرفنا النهارده ونقول برزنتيشن للبيدياتريشن الجنرال بيدياتريشن عن الاكيوت لور ليمب ويكنس. دكتور عايده، حضرتك موجوده؟
السلام عليكم.
اهلا بيك دكتور عايده.
سلام.
ان شاء الله كل عام وانتم بخير مره ثانيه، واهلا وسهلا فيكم جميعا في ليله من ليالي رمضان الكريم لهذا العام المميز. وطبعا احنا معكم مره اخرى من اليمن، ومعنا ضيف جديد اللي هو الدكتور احمد صلاح الدين، استشاري طب الاطفال، طبعا تخصص نيورولوجي، وحيقدم لنا Acute Lower Limb Weakness. هذه موضوع طبعا هذا من المواضيع الكومن، يعني خصوصا في اليمن، واعتقد كمان الدول العربية بشكل عام، واسبابه كثيرة. وحنستمع الى الدكتور احمد الى هذا التوبكس الجميل. واهلا وسهلا فيك دكتور احمد، وشرفتنا، وشكرا لك على بيت الدعوة دائما.
الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. I'm very happy to be honored to present today, and a special thanks to Dr. Bahar Sheikh, Dr. Mohammed Hilan, and of course our senior, Dr. Aida, for giving me this opportunity to speak about this important topic. So, the acute lower limb weakness in children and as well as adults and other peripheral neuropathies exhibit similar clinical as well as electrophysiological features. And the incidence and the nature as well of the underlying disorders responsible for peripheral nervous disease are widely divergent. And perhaps the most salient difference is that most peripheral nerve disease in children are immune mediated and potentially treatable. The most important thing in acquired inflammatory neuropathies were the most common peripheral nerve disease in this age group, followed by genetically determined neuropathies. And as well as we discussed with the organizing committee about this talk, so it will be like a clinical case scenario. Then we will go through the case bit by bit, and inshallah we'll start now. Okay, so our objectives for today is the case scenario, as we mentioned. Then we will try to localize where is the problem, and then we will pass through the differential diagnosis, then evaluation, as well as the management for the case. So we have a 12-year-old boy seen in your office on an urgent basis for complaints of lower extremity weakness. The patient was in his usual state of health until that morning when he noticed that his legs were weak when getting out of the bed. His symptoms seems to be getting worse because now he is having difficulty walking. The patient does not have any medical problems. He had an upper respiratory tract infection like all of his friends about 2 weeks ago, but he did not experience any fevers. He plays football, but denies any recent trauma. His physical exam, vital signs, he's afebrile. In general exam, there is no nuchal rigidity or papilledema or other signs of meningitis. His mental status, he's alert, He has fluent speech without dysarthria. His cranial nerves, his pupils are equal, round, reactive to light. His extraocular muscles are intact. His facial movements are symmetric and without weakness. There is a strong gag and his tongue is midline without fasciculations. He has normal bulk in motor with mild hypotonia in lower extremities. His power and strength in the upper limb is 5/5, and there is no pronator drift. The lower limb strength is 3/5. There is no dysmetry as noted. He has intact to light, touch, temperature, vibration, and proprioception. In his gait, he's unable to walk unassisted. His reflexes is absent in the lower extremities and trace in the biceps as well as the triceps. And he has bilateral plantar flexor responses are appreciated. So to summarize this case, he's a previously healthy 12-year-old boy who presents with an acute progressive ascending paralysis in the setting of a recent viral illness. His neurological examination demonstrates proximal as well as distal lower extremity weakness and areflexia without apparent sensory abnormalities. So there is anybody can tell us where is the localization could be in such case? I love the interacting session so we can benefit it more. Okay. So as you know, we have the levels in the nervous system. We have the central nervous system as well as the peripheral nervous system. The central nervous system composed from cerebrum, which is the cortex, as well as basal ganglia, cerebellum, brainstem, and spinal cord. The peripheral nervous system consists of roots, plexuses, peripheral nerves, neuromuscular junction, and muscle. To elaborate more, so there is signs for upper motor neuron lesion as well as lower motor neuron lesion. So in upper motor neuron, you have diffuse atrophy, which is for long standing, but you have spasticity, hyperreflexia, extensor plantar reflex, normal conduction velocities, and no denervation potentials in EMG. For lower motor neuron, the patient will have, as well as he will have weakness, and the weakness is different here from upper motor neuron. He have wasting, marked wasting, and it will be early, not like the upper motor neuron. He will have flaccidity, loss of reflexes, hyporeflexia, fasciculations, and the nerve conduction velocity will be abnormal. And for sure, he will have denervation potentials in EMG. So in localization here, the lower extremity weakness and areflexia in such case is most likely localizes to the motor unit and more specifically to the peripheral nerve. Because why I'm saying that? Because the patient is alert, awake, there is no encephalopathy, there is no seizures. So most of the signs denote and can guide you that this is a peripheral nervous system involvement. The other primary consideration also might be sensory process involving the spinal cord, although there is no comment in the VINET regarding a sensory level or sphincter tune. And the sensory examination provided appears to be normal. There is no history of bowel or bladder incontinence or back pain. That would be more suggestive of a spinal cord process. Also, the plantar responses are flexor, and there are no long tract signs. Thus, that the disorder of the peripheral nerves seems to be more likely. So, can anyone just suggest any differential diagnosis for such case? Anyone?
ممكن أي زميل من الزملاء المتابعين يكتب في الشات.
Yes, please.
question.
في question answer فوق GPS.
لا ما أعرف شرعي. Excellent. Differential. Anyone else?
يعني الحالة حالة acute flaccid paralysis، واخدة الموتور يونت، sensation good. يعني الشباب
Okay.
يلا. معلش النيورو بعافية مع الناس أنا عارف. الشات مقفول. طب ما هو أنت بتكتب أهو في الكويتشن تانسر. افتح الشات كده يا دكتور أمير. إحنا فاتحين الشات يا جماعة. الشات أهو. الشات
Open.
شغال.
رنا
الشات
سمير.
كده أنا بعت رسالة أهو.
Okay.
يلا يا شباب احنا هنأكد على ان الشات شغال، بس عاوزين
Okay.
نسأل
Excellent.
جلاند بري سندروم برضو. طب ما فيش اي
Excellent.
حاجه ثانيه كده؟ انتوا داخلين على الدياجنوستس على طول. طب ما هو في ديفرنشال وبعد كده نوصل لجلاند بري.
Yeah.
ماشي كونتينيو يا دكتور احمد. اتفضل.
Okay. So in the differential diagnosis such case, as our colleague mentioned, okay. So the differential diagnosis of Guillain-Barré syndrome involves CNS, anterior horn cell, and neuromuscular junction disorders, in addition to other peripheral nerve as well as muscle diseases. But the diagnosis of Guillain-Barré can be especially challenging in very young children or infants who may not be able to articulate their complaints and who may not cooperate with a formal neurological exam. And there is reported cases that the youngest one has Guillain-Barré is 40 days old. 40 days old. Neurological emergencies such as Guillain-Barré and acute spinal cord lesions should always be considered first in a child presenting with an ascending paralysis. The demyelinating diseases are for sure, like transverse myelitis, acute disseminated encephalomyelitis, spinal cord tumor, spinal cord trauma, epidural abscesses, or cord infarction may present all with similar features. They may be associated with acute or subacute progressive leg weakness, paresthesias, numbness, back pain, as well as areflexia. The neuromuscular disorders such as myasthenia gravis may present with weakness as well as areflexia. But the onset of symptoms, pattern of weakness like ptosis, ophthalmoplegia, proximal weakness, and slower progression of weakness usually help you to differentiate myasthenia gravis from others. The inflammatory myopathies, such as viral myositis, polymyositis, and dermatomyositis may present with lower extremity weakness as well as pain. But one of the differential here is the serum CK is usually elevated, whereas CSF and electrodiagnostic studies are normal. The broad differential diagnosis of acute weakness may also include other muscle diseases such as metabolic myopathies, like in case of mitochondrial disorders of carbohydrate and glycogen metabolism, as well as the periodic paralysis syndromes, like the hyperkalemic or hypokalemic periodic paralysis. These disorders should produce more generalized weakness and can usually be differentiated on clinical presentation. But in this age group, Guillain-Barré syndrome may present with ataxia as a consequence of muscle weakness that may appear to be either sensory ataxia or cerebellar disease. But in fact, when you do cerebellar exam, it will be normal. A thorough neurological exam, which is the cornerstone and can help you to differentiate all these differential diagnoses with the history, it can guide you to where is the problem is or where is the lesion should be. The musculoskeletal abnormalities such as toxic synovitis or fractures may enter the differential if a child refuses to walk or experiences significant lower extremity pain. Poliomyelitis, especially that we have an outbreak, as well as because of the reduction in vaccine. So they can cause ascending paralysis, but usually in the setting of an acute illness and causes asymmetric weakness. Finally, symptoms that affect the peripheral nerve should also be considered. As we mentioned, Dr. Bahaya asked about why
احنا عاوزين نبقى مور سمبليفايد بالنسبه للزملاء. فحضرتك من خلال كلامك ان احنا ممكن يكون عندنا مشكله في الريسبونس. اوكي صح كده؟
يس.
طب تمام. ريجاردنج هناخدها ديسكشن مع حضرتك، هاخدها ديسكشن مع حضرتك عشان بس نبقى كلاريفاي للزملاء المعلومه. رقم واحد الهيستوري اهميته معانا هنا ان احنا نفرق ما بين ده وما بين ده وما بين ده. انا عندي ليجن في النيرف، عندي ليجن في المصل، عندي ليجن في الانتيريور هورن سيل، انا عندي بولي نيوروباثي بوست انفكشوس. اقدر اظهر بيها ازاي كهيستوري؟ اسال ازاي؟ يعني انا جاي لطفل الطوارئ دلوقتي، اوكي، وانا كنايب جونيور موجود في الطوارئ، الاب جاي يقول لي الولد ده مش قادر يزك على رجله، مش قادر يحط رجله في الارض ومش قادر يمشي. فانا اساله طب الكلام ده حصل من امتى؟ الكلام ده حصل من 5 أو 6 ايام. How to proceed regarding collecting the history.
So thank you, Dr. Baha, for asking this question. So this is the most important, as we mentioned in such case, the collecting history and data is trying to help you, and you can reach a diagnosis for almost more than 80% in such cases, or in all medicine, in all branches of medicine. But in neurology, it's stepwise to take detailed history as well as thorough exam and plus or minus neurodiagnostic or electrophysiologic. So in such case, if you have patient comes to you with a complaint that he's unable to walk, you will ask first, this has happened since when? So is it progressive? Yes, the father will tell you that it's progressive. So is the patient was sick in the past 6 weeks, 4 to 6 weeks, any upper respiratory tract infection, any gastroenteritis like vomiting, diarrhea, abdominal pain. This is very important in history of Guillain-Barré. But in a spinal cord lesion, especially if the patient comes to you, he's well and he comes suddenly, the father will tell you just in 2 to 3 hours, he's unable to walk. And there is sphincter and bowel problems. So you can, at this age, you can suspect, with this history, you can suspect spinal cord infarction. But most probably, if the history subacute, 3 to 5 days, 6 days, 7 days, inability to walk, or little bit some sort of ataxia or walking unassisted, so this will be toward most probably toward peripheral nervous system, like Guillain-Barré.
تمام. يعني نقدر نقول ان احنا عندنا البروجريسيف كورس الأونست من 4-5 أيام with history of gastroenteritis كGIT infection. ده يليدنج us ان احنا داخلين في نفكر في Guillain-Barré. لكن وايل لو احنا عندنا sudden onset hours بلس ان هو جاي يشتكي من باول او السفنكتر uncontrolled sphincter، دي نقطة مهمة. يبقى الترانسفيرس مايلايتس بتيجي sudden onset hours ومعاها من الأول الباول uncontrolled باول urination defecation uncontrolled. مظبوط كده؟ تمام. اتفضل.
So this is the most important thing that, as Dr. Baha mentioned, so the history, collecting the piece of history is most important. So why this is important? This will guide you how to diagnose and when you will ask for proper other paraclinical, like you will ask for CT if you suspect that the patient has like transverse myelitis, spinal cord infarction. So you will ask about that. But if the patient have like peripheral nervous system, 5-6 days history of unable to walk, a history of upper respiratory or gastroenteritis in the past 6 weeks, or even sometimes in rare cases up to 7 to 8 weeks, So you will know that most probably this patient have peripheral nervous system problem, which could be Guillain-Barré syndrome. So you will go for physical exam. So you will find that the patient is alert, awake. He's not encephalopathy. He's not having any seizures. Then you will find like he's having hypotonia, weakness in the lower limbs. And the most important thing is the reflexes. The reflexes is a very big clue to guide you. Is this a peripheral nervous system or central nervous system problem?
قاطع حضرتك معلش. بالنسبه ان احنا دلوقتي في الهيستوري كولكتنج قدرنا من خلال الهيستوري نحدد احنا عندنا سكه سباينال كورد ولا سكه جلامبري. ناقص لنا البوست فايرال مايوسايتس، يعني هيجي يشتكي برضه بليمب ومش قادر يمشي، لكن اعتقد هيبقى فيه تندر مصل.
So the most important thing here, thanks for pointing to myositis, because it's very important. So most probably they will, as Dr. Baha mentioned, that they will come and complain of pain. So as you know, you will ask for the CK, you'll find it high, and you will do the other, as you know, it will direct the management. And in the myositis, the reflexes will be normal. Most probably.
نقطة كمان نقدر نعمل لها برضه confirmation معانا regarding collecting الهيستوري برضه يا شباب، إن لو الطفل أو الأب قال لك دي ريكارنت، دي حصلت من شهرين 3 ورجعت تاني دلوقتي والكلام ده، فنفكر هنا في البريودك باراليسيس، الكترولايت امبالانس زي الهايبوكاليميا، هايبركاليميا، تعمل معانا بريودك paralysis.
Excellent, Dr. Baha. And this is one of the common things if you face recurrent lower limb weakness. You should, as Dr. Baha mentioned, you should suspect the periodic paralysis, especially the potassium. So you should do the electrolytes, and you will find either hypo or hyperkalemic periodic paralysis, and they have different setting of investigations, and you will find them also, as Dr. Baha mentioned, you will find that the deep tender reflexes is normal in such cases, most likely.
إذا الهيستوري يحدد معاك أنت فين بالظبط، وحاجة واحدة لازم تتدرب عليها في الإكزامينيشن مهمة في الأكيوت لور ليمب باراليسيس، هي الريفلكسز. إزاي تعمل الريفلكس صح، علشان هيبقى عندك لا اما نورمال ريفلكسز نورمال، فاحنا ممكن بالهيستوري لما نيجي نبني على الهيستوري وتندر ماسل، فاحنا كده دخلنا في سكه مايوسايتس. عندك اريفلكسيا وعندك هيستوري ان هي بقى لها 5 سيكلي هيستوري ان كان في جي اي تي او ريسبيراتوري تراكت انفكشن، فانت كده سكه جلامبرين صدم اورز، يعني هيبقى في شويه هايبر ريفلكسيا، اذا يعني قدرنا نقول ان في هايبر ريفلكسيا، او ممكن تكون في الشوك ستيج لسه، فيبقى في شويه هايبر ريفلكسيا، فانت في سكه ترانسفيرس مايلايتس. هل هذا الكلام مظبوط دكتور؟
نعم مظبوط دكتور بهاء. Especially for transverse myelitis, there is another only one thing, that the transverse myelitis they will have sensory level. So when you do, yes, they will have sensory level at T10 here at the mid of the abdomen. So they will lose the sensory from up the umbilicus till the 2. They will not have any sensation, most probably.
تمام.
Because as you mentioned, they will have spinal cord problems and infarction. Yes.
إذا أنت عندك سنسوري ليفل، كلمة سنسوري ليفل بنقراها في الكتب وإحنا مش واضح لنا يعني إيه سنسوري ليفل. حضرتك هتيجي تعمل السنسيشن من عند الأمبلايكس، هتلاقي الولد مش حاسس، خلاص ماشي. هتعمل من عند الأمبلايكس، هتاخد من جوه لبره كده، خلاص تاتش كده بالراحة على فوق مستوى الامبلايكس على طول، وعلى مستوى الامبلايكس وتحتها. هتلاقي الطفل هنا يقول لك هو ما هوش حاسس وما فيش اي سنسيشن. هتبتدي تنزل لتحت، هتلاقي برضو عندك لوست سنسيشن. ليه بنتكلم في حته السنسيشن يا شباب بالذات في المنطقه ديت؟ لان انت الطفل ممكن يكون في ترانس ترانسفيرس مايلايتس لكنه في الشوك ستيج، فما فيش لسه الهايبر ريفلكس تطلع معاك، فانت هنا تحتار هو انا كده جلامبري ولا كده ترانسفيرس مايلايتس. ساعات الهيستوري مش هتقدر تاخده من الاهل مظبوط، فلما تيجي الموضوع يختلف معاك فانت هنا تبقى قادر ان انت تحدد من خلال السنسوري ليفل. عندك الجراند بري ده موتور افكشن هيبقى فيه اريفلكسيا من الاول، لكن السنسوري ليفل هيكون مع الترانسفيرس مايلايتس ومعاها من الاول الباول ان كنترول باول. تمام كده؟
Excellent. Any other
اتفضل بروسيد يا
question in
فندم.
such area?
اتفضل يا فندم.
So as we mentioned here, this is like a differential diagnosis of Guillain-Barré. So just as we discussed now with Dr. Baham, mashallah, he's almost a neurologist. So he mentioned the most important thing in the spinal cord. You should suspect the demyelinating disorders like transverse myelitis. You should also suspect infarction if there is acute presentation, as well as with the transverse myelitis. The poliomyelitis, as you know, the child will be unvaccinated, usually younger age. There will be asymmetric paralysis. The neuromuscular junction, tick paralysis, we don't have in our countries. This is in Western. Myasthenia gravis, as well as botulism. So botulism, it will be in younger age and it will not be ascending, it will be descending. So it will be from the eyes and eyebrows to down. And the peripheral nerves, the GBS, which is our talk today about, and its variants, and the chronic inflammatory demyelinating polyneuropathy, which is the chronic type of Guillain-Barré. So the difference between both, that in the chronic inflammatory, from the name itself, so it will be according to the criteria, it will be more than 2 months, so 8 weeks of weakness. The muscles, myositis, either inflammatory or infectious or post-infectious, metabolic myopathies, as well as periodic paralysis syndromes. So just, I want to give you a small picture. This is my small town where I was raised. So it's very beautiful area. And we have a bunch of waterfalls, bunch of green areas, as well as kind people.
دي فين يا دكتور احمد؟
This is in E.U.P province, محافظة E.U.P.
في اليمن؟
Yes.
جميلة خالص، الله أكبر. اليمن السعيد.
So in evaluation, we should do a lumbar puncture initially to be performed, so to evaluate the CSF for what we call it albuminocytologic dissociation. So what do we mean by albuminocytologic dissociation? That's mean that the protein will be high, but the WBCs will be normal. So in order to rule out if there is any infectious process, this is the first clue that this is Guillain-Barré. Typically, the protein is elevated from 80 to 200 milligram per deciliter, whereas the cell count is normal. Sometimes you have it till 5, 10, but it will be normal. But usually if you do proper lumbar puncture, they should be 0. However, the CSF protein may be still normal within the first week of symptoms. So if the patient comes to you like 2 days history and you do lumbar puncture on the spot, so sometimes you will find that the CSF is normal. So the CSF protein is normal. So do not panic. So if you suspect the diagnosis, just try to postpone the lumbar puncture like to the 3rd or 4th day, it will be better. The EMG and NCS can also be helpful and in differentiating motor versus sensory nerve involvement. And the most important is the classic nerve conduction abnormalities are consistent with the demyelinating process, which is the most common type, which is called the EDIP, the acute inflammatory demyelinating polyneuropathy. It will include prolonged distal latencies, loss of prolongation of F wave, slowing conduction velocity. So the slowing of the conduction velocity itself, so This is the most important in EMG, in EMG patients, in NCS, in patients with Guillain-Barré, because it will guide you that this patient have demyelinating, which is the most common type. If you find that the conduction velocity is normal in such case and you suspect Guillain-Barré, so this will carry most probably a poor prognosis, because the patient will have weakness more. So, and more likely he will have another modalities of management rather than the IVIG like plasma exchange. The spinal MRI with gadolinium is also performed as precautionary measure to rule out spinal cord pathology, particularly if you suspect, and this is atypical case or in very young children who may have difficulty providing history or sometimes cooperating with a formal neurologic examination. And in the emergency, one of the most important thing that you should do is to do pulmonary function tests with negative inspiratory pressure as well as forced vital capacity, and you have to measure the oxygen saturation. In its variants, like Miller-Fisher, you test for GQ1B antibodies if you are suspect, and Miller-Fisher variant consists of ophthalmoplegia and areflexia and atypical weakness. So this is just in diagnosis. And serum antibodies, IgM and CSF, this is just will help you to further to find like the triggering factor, like especially in cases of Campylobacter jejuni. Here, the clinical and laboratory features in diagnosis, as well as areflexia, loss of ankle jerk reflex, and diminished knee and biceps reflexes, they were suffice to establish the diagnosis. So strongly supportive in such case, if there is a progression of weakness that may develop rapidly but cease to progress after 4 weeks, and likely roughly 50% will plateau within 2 weeks, and 80% within 3 weeks, and more than 90% after 4 weeks. So there will be relative symmetry, mild sensory signs or symptoms, with sometimes there will be cranial nerve involvement. Facial weakness develop in about half of patients, but usually it will be symmetric involvement. Sometimes most of the time they will have autonomic dysfunction, like sometimes they will have tachycardia, bradycardia. So that's why function test in the emergency, you should also inform the PICU. So you should involve the intensive care unit and tell them that I have highly suspicious of Guillain-Barré syndrome in the emergency, and I need you to assess this patient. Probably he will deteriorate overnight.
استاذن حضرتك دكتور احمد.
Yes, go ahead please.
احنا شباب بنبقى استقبلنا الحاله في الطوارئ، فاحنا عاوزين نحدد الحاله ديت هتروح فين. فالحاله ديت هتبروسيد ان هي تخش البيكيو. ففيتال از فيتال، فيتال ساينز از فيتال. ليه؟ اوتونوميك مانيفستيشن ولا لا؟ اوتونوميك مانيفستيشن لابايل هارت ريت، برادي كارديا، تاكيكارديا، بيبقى لابايل. عندك البلاد بريشر لابايل، شويه هايبوتنشن، شويه هايبرتنشن. السبيرومتري از مانداتوري، لان انتوا عارفين ان هو اسندنج باراليسيس بيحصل، فانت تشوف الدايفرام خلاص هيتاثر، الانتركوستال ماسلز كمان هتتاثر ولا لا. فبالتالي انت بتعمل ايفالويشن للبالمونري فانكشن، على اساسها تحدد انت هتبقى ستاند باي فينت لهذا الطفل ولا مش ستاند باي فينت لهذا الطفل، لانه ان كان هو مستحمل ومكمل فهيجي له وقت وهيبقى فيه فاتيج ماسل، وبالتالي هذا الطفل هيكون محتاج ان انت ستاند باي فينت. تمام دكتور احمد؟
Excellent summarization. So in management, as we know, the Guillain-Barré should be recognized as a neurologic emergency. Any child presenting with suspected GBS should be admitted to the hospital for diagnostic testing as well as management. Assessment and stabilization of the airway, breathing, and cardiovascular status should be done immediately, as Dr. Baha summarized. So there should be ongoing monitoring for autonomic instability. Patients with rapid progression of symptoms or respiratory compromise require close observation in the PICU. Treatment of Guillain-Barré involve administering of IV immunoglobulin, which is the cornerstone in such cases, and it's very important to be administered the patient. You saw the patient and he's doing well, like he's after 1 week he presented to you and he's, according to his father, now he said he's sitting, now he's making few steps, he's doing better. You can follow up this patient. But the most important thing for such patients, when you admit the child to the hospital, you should initiate physiotherapy and occupational therapy. Believe me, it will help those kids and will lead them back to their baseline of life immediately. The mechanism of which these therapies work are still not well understood, but the IVIG act by binding pathological antibodies or by decreasing the B cell antibody production. The plasmapheresis, as we mentioned, but usually we are not using it in demyelinating type, which is the common type of Guillain-Barré syndrome, because from the tens of cases that I have seen so far, they respond well to the IVIG, in addition to physiotherapy as well as occupational therapy. But the patient that we tend to use the plasmapheresis, those patients with the axonal type of injury, not the demyelination or the myelin injury in the nerves. So the axon, as we mentioned in the electrodiagnostic nerve conduction, you'll find that there is normal conduction velocities, as well as the history will be different. Sometimes with the axon, the course of itself, the disease progression will be very aggressive. And sometimes you thought that there is spinal cord problems. But most of the time, when they present with the axonal or with the axonal sensory, the AMAN or the AMSAN variants of the GBS, the history of present illness will be very, very aggressive. And the patient can have also cranial nerve involvement, like facial nerve. Sometimes they will have ophthalmoplegia. At this time, there is no prospective randomized trials comparing the two therapies in children, but there is some papers regarding the IVIG as well as the local experience, at least here in Saudi Arabia, or as well as in the West, when I have seen cases. So it's thus thought that it's likely the IVIG and plasmapheresis have similar efficacy at lowering morbidity by decreasing the cost of the illness and speeding the recovery time. So when a child is mildly affected, remains ambulatory, or in cases with neurologic symptoms have plateaued, therapeutic interventions may not be required, but you should keep an eye on this boy and keep follow up him. The conventional dose, as you know, is 2 grams per kg. You can give it over 2 to 5 days if the patient did not have an IVIG before. So I prefer to give it over 4 to 5 days, not less than that, so to minimize the side effects. So as you know, the side effects can be allergic anaphylaxis, which is in particular in patients with IgA deficient individuals. They will have more than 50% of the patient, they will have headaches, myalgias, fever, and on rare occasions, they will have aseptic meningitis. So the GBS can be severely disabling and recovery can take few months. But as I mentioned earlier, if you commit the patient on PT and OT, the outcome will be magnificent. In addition, as pain may be significant sometimes on such cases, administering of painkiller is warranted And I do prefer in such cases not the regular Profen or paracetamol. I prefer to give in such casing the gabapentin. So I will reach to my last slide. So any questions from the audience?
رقم واحد انا حابب اتناقش مع حضرتك في regarding اخر حاجه نعملها summarization مع بعض في about المانجمنت. رقم واحد حضرتك قلت المانجمنت بتاعنا اي في اي جي. اوكي طيب regarding الدوز.
Sure. So it's 2 grams per
2
kg.
جرام.
Maximum per day 60 grams. So if you have, let's say, patient, his body weight is 10. So we will give him 2 multiplied by 220. So 20 will divide them on 3 to 4 days. Okay.
Okay.
So we'll give 5, 5, 5, 5.
اوكي يعني as a total dose والتوتال دوز ديت as a total dose about 10 كيلوغرامز هيبقى الجرعه 20 جرام اي في اي جي هيتقسم على 5 ايام 20 على 5 هياخد 4 جرام كل يوم. صح كده؟ تمام
مظبوط.
طيب ادانا الاي في اي جي والطفل لسه بروجريس مفيش تحسن ولسه ريفلكسيا ولسه في بروجريشن وبدا يبقى عندنا مشاكل لسه ما تحسنش. هل عندنا القدره ان احنا نعمل تاني ريكارنس دوز للاي في اي جي نكرر الجرعه؟
طيب excellent question. So in such cases most probably the typical Guillain-Barré syndrome they will not progress. So if you give IVIG on the 3rd, 4th day, even if the case will plateau, so there will not be deterioration. If there is a deterioration, this will not be, from what I have seen and I have read, this is not typical GBS. So this is atypical most probably. So you can repeat the IVIG definitely for such patient. You can repeat the IVIG, especially if the nerve conduction study there is severe involvement. You can repeat the IVIG. Just give like few days window, like 4 or 5 days from the first cycle to the second cycle. Don't give it immediately.
تمام. طيب يبقى هنا عاوزين ندور على اوبشنز لهذا الطفل برضو الاتيبيكال. هنا اختار البلازما فاريسز ولا الكورتيكوستيرويدز؟ والكورتيكوستيرويدز بنستخدمها في الكرونيك كيسز علشان في ديبيت على الموضوع ده.
Excellent. طيب.
اتفضل.
For the chronic cases اللي هم CIDP patients, we prefer to use the IVIG. Still number one, I prefer to use the IVIG. The steroids, it will be short term and it will be very minimal doses. So we'll not give pulse steroid therapy for such cases. And I do prefer for such atypical cases, if they did not respond to IVIG, and I will give physiotherapy, occupational therapy, and I will give gabapentin, and I have not seen any improvement, but you can say there is plateau or there is some sort of mild decline, I will go for plasmapheresis. But in such cases, for my experience for the past 10 years, I have seen tens of GBS or atypical GBS or CIDP patients. Lillah alhamd, most of them they respond to IVIG, and just few of the CIDP, which is the chronic type, with IVIG, for some patients, like we do have 3 patients, CIDP patients, so they respond to the IVIG on 2 months time. Every 2 months we give them IVIG. They will admit it overnight, 2 days, and they will go home. They will receive the IVIG. So such cases, you will give it for like 1 year for the CIDP patients, and with minority, you will give like steroid 5 milligram once daily for like 1 month. Then you will start to taper for 2 to 3 months. So there is no specific guidelines for such whole patients. So each patient is individual, as you know, in medicine. So I'm reacting depending on each clinical presentation, and each patient comes to me.
يبقى نعيد تاني شباب بعد اذن حضراتكم. الاي في اي جي هو يور تارجت، هو
Yes.
الموداليتي، هو المانجمنت، مش الكورتيكوستيرويدز.
No.
الكورتيكوستيرويدز في الاتيبيكال، وبعد ما نكون خدنا قرصين من الاي في اي جي بينهم 3 أو 4 ايام راحه. وكمان لو هندي اي في اي جي مش هندي بالس ستيرويد، احنا هندي على جرعه 1
Yes.
مللي جرام بير كي جي لخلال شهر، ونعمل تابرنج من بعد الشهر على شهرين، بحيث ان احنا نكمل 3 شهور على الكورتيكوستيرويد. ده امتى؟ لما نقول ان احنا الطفل ده بقى كرونيك جي بي اس، الطفل ده استخدمنا معاه الاي في اي جي وما تحسنش. فاذا عندنا موداليتي اخر قبل الكورتيكوستيرويد هو البلازما فاريسيس. مظبوط دكتور احمد؟
Yes.
تمام. البلازما فاريسيس، ريجاردنج البلازما فاريسيس، احنا بندي مثلا كام سايكل على البلازما فاريسيس حضرتك من خلال يور اكسبيرينس في الموضوع ده؟
4 cycles most
استخدمته
probably.
قد ايه يعني؟
Just 2 to 4 cycles. Usual 4 cycles. We'll wait and see. Most of them will improve after the plasmapheresis, which we use it for only one patient before, and alhamdulillah it gives such improvement.
تمام. تاني بعض الدكتور جابر العربي بيسأل معلش how to detect sensory level in transverse myelitis please. احنا قلناها قبل كده دكتور احمد، تفضل معلش مشكورا نقولها تاني علشان الشباب.
No worries. So by physical exam, as Dr. Bahar mentioned in the slide, so when you have patient with transverse myelitis, you should do sensory exam. You know, in sensory exam, there is light touch, crude touch, pin and prick. So when you do touching from the two till the umbilicus, there will be no sensory. Sometimes there will be no sensory at all, or just minor sensory. So if you go up the umbilicus, which called T10, above that, he will feel, the patient will feel. And when you do the MRI imaging for the spine itself, you will find there is lesions up there.
ببساطه شديده يا شباب، انت معاك خله السنان، انت معاك اي شارب اوبجكت، يعني انا هتكلم ريجاردنج مصر طبعا، خلاص ماشي. معانا المفاتيح بتاعتنا، انت بتعمل السنسيشن، الولد مش حاسس، توصل لغايه الامبلايكس مش حاسس، فوق الامبلايكس حاسس، تحت الامبلايكس مش حاسس. ده بنسميه ايه؟ بنسميه السنسوري ليفل. فوقه حاسس، يعني احنا عندنا ليفل فوقيه الطفل حاسس، تحتيه الطفل مش حاسس، ده كلمه سنسوري ليفل. هتعمل ام ار اي على السباين، هتلاقي عندك الليجن، بنديله صبغه غالبا دكتور احمد.
Sorry.
بندي صبغه في الام ار اي سباين.
Yes, sure. لازم. Gadolinium it should be.
تمام. الجادولينيوم. تمام. طيب what is the interval after IVIG when to be followed by plasmapheresis?
It depends. Sometimes we give like 1 week to 10 days to see the patient well and to examine him well and to give room for IVIG to work, as well as physiotherapy and occupational therapy to work.
تمام.
But minimum week.
في اني رول للجابتن هنا؟
What?
الجابتن.
What?
الجابابنتين.
Yes, gabapentin, yes. Especially if there is pain, I mentioned it from the slide. And if there is pain, I do prefer to use painkillers like gabapentin because it's helping neuropathic pain. So it's not muscle, it's neuropathic pain. So you have to give gabapentin.
تمام.
It's very effective.
يعني هو سؤال تراديشنال شويه، بس في الرورال
okay.
اريا، في الرورال اريا، في المناطق الطرفيه، في البعيده، دايما بنواجه ان في مشكله في توفير الاي في اي جي. بعض شويه مستودعات الاي في اي جي ما بتبقاش متاح فيها الاي في اي جي. هل هنا على ما يتوفر الاي في اي جي ممكن ابتدي كورتيكوستيرويدز؟ ده سؤال من دكتور جابر في العربيه.
advise. I don't advise. Rule is rule, and you have to, yes, and you have to refer him.
IVIG.
Unless
yes, IVIG
yes,
is the mainstay of
and
treatment.
the corner stone. Unless the patient cannot be traveled, unless the patient cannot be transported by ambulance, which I don't think so. But if there is no way Apart from that, just give it. But for me, the cornerstone is the IVIG. Believe me, it will change the patient's life.
Yes.
ممكن
اتفضل دكتورة عايدة.
دكتور أحمد،
تفضل
إذا يعني نتكلم على البريفنشن، يعني it can be prevent this disease or no?
لا, unfortunately we cannot prevent this disease because it's inflammatory and autoimmune, so we cannot prevent this disease.
أنا قريت مرة في إحدى الصحف وكذا إنه في هناك في محاولة لفاكسين، صحيح الكلام ده؟
there is a neurology field. There is a lot of lights صراحة, especially I know you are coping with the spinal muscular atrophy, the management, the Duchenne muscular dystrophy. There is management. So I think at the end of the tunnel there will be like a vaccine. But for such cases in Guillain-Barré, I don't think they can find something. I don't know, because it's autoimmune disorder. It's not genetic disorder. It's autoimmune, and so far they don't know why the T cells or B cells, or even sometimes in genetic disorders like why the Schwann cells will be attacked, like in Charcot-Marie tooth. So for this autoimmune disorders, I don't think the vaccine will help, like you mentioned, like in SLE patients. So it's autoimmune, we know that, and so there will be like, I don't think the vaccine will be available soon. I don't know.
What is the
Thank you.
Okay, what is the IVIG regime you prefer, Dr. Ahmed? 2 days IVIG or 4 to 5 days?
I prefer 4 days. So it depends. So if the patient comes to you and I prefer, if the patient did not receive any IVIG before, I prefer that to take it 3 to 4 days, 5 days, but not in 2 days. It should be 3 to 5 days. And sometimes we do it, so we calculate it upon the bottle. So in the bottles that we have per each bottle, we have 5 grams. So I cannot give the patient like 11 gram and drop the 1.5 grams. You know, it's very expensive. So we try to calculate the dose based on the bottle container. So the bottle itself here we have in Saudi Arabia is 5 grams for each bottle. So if patient, like we mentioned, 10 kg, so we'll give 20, we'll give like 4 bottles. So 4 days. So 5, 5, 5, 5.
So when to assume that our patient is chronic GBS بعد قد ايه؟
8 weeks. شهرين.
8 weeks.
شهرين.
بعد شهرين.
ايوه.
الموداليتيز بعد شهرين في التريتمنت regarding التريتمنت يبقى ايه؟
IVIG number 1. I have seen more than 10 cases with the CIDP. Start with the IVIG and intensive physiotherapy. Inshallah, but I don't have the video. I have one famous girl come to us. She has weakness for 6 months and she traveled abroad to 2 major countries. There was no diagnosis, unfortunately. She came to us when we diagnosed her with CIDP, and she came to us bedridden. We gave her IVIG, 2 cycles. We referred her to inpatient physiotherapy, occupational therapy for 3 months. And subhanAllah, she can run now. She's doing very well.
طيب, regarding the nerve conduction,
yes.
منتظر يتحسن بعد قد ايه؟ يعني نعيده بعد قد ايه؟ ونلاحظ فيه تحسن بعد الاي في اي جي.
So I don't prefer to repeat the nerve conduction studies, especially after the IVIG. After the IVIG, you can see the improvement in the patient by clinical exam, by the patient face looking to you. But the nerve conduction study, I don't advise to repeat it soon. At least 6 months to 1 year, because you know this is nerve and this is myelin. So for nerve to be repaired itself, usually the nerve growing around 4 millimeters per day. So just see if you have like 50 centimeters for how long this will be corrected. So the ideal situation, just do it as a baseline, especially in patient with the typical GBS, and don't repeat it again. But if the patient have like CIDP, you can do it, then manage, and you can do it if you want just to, for your knowledge, or if you are interested in neurophysiology, you can repeat it. But I don't advise to be repeated frequently. Just do it once and that's it.
تمام. طيب انا عندي طفل جالي مثلا وعنده ويكنس وماشي في كرايتيريا بالهيستوري وماشي في كرايتيريا بالكلينيكال اكزامينيشن ان هو جلان بري، لكن جينا عملنا الاي ام جي النيرف كوندكشن نيجاتيف، ما فيهوش مشكله. هنا بروسيد از جراند بري سندروم ولا نعيد تاني نيرف كوندكشن بعد يومين ثلاثه؟
If the patient is typical GBS, there should be something in the nerve conduction study. Otherwise, there should be another diagnosis. The lumbar puncture, yes, it's patient GBS. There should be something on the nerve conduction study, definitely.
كده احنا عملنا كفرج لكل الاسئله اللي جات لنا. في اي اسئله ثانيه يا شباب؟
لا شكرا يا
دكتور
استاذتي
أحمد،
القديره.
شكرا.
اي وقت.
يعني محاضرة جميلة ويعني واجابتك جميله واسلوبك جميل، وانا اول مره
لا انت
يعني
ايام ما
اتشرف
كنا
فيك
في
طبعا.
الريزيدنسي كنت اشوفك كده
الدكتور
بس
محمد
المحك
عارف
ما كنتش معاك.
ان شاء الله خير. دكتور بهاء طبعا انا اول مره اتشرف
لا
فيه.
بالعكس دكتور بهاء ما شاء الله هيز 95.5 نيورولوجيست.
اهلا وسهلا بحضرتك، ده انا على قدي خالص والله.
لا اكسلنت.
اخر حاجه، احنا شباب لما بتبتدي دكتوره بسمه سيف لها، انا سالت كل الاسئله اللي حضرتك قلتيها، ناقص سؤال واحد، ريهابيليتيشن تو بي ستارت فروم فيرست داي. وانس ان انت دايجنوزد طفل جي بي اس، وانس ان هو معاكي في البيكيو، الريهابيليتيشن نبتدي على طول علشان نتجنب الديسيوز اتروفي، نتجنب الكونتراكشرز اللي ممكن تحصل لهذا الطفل. وانا كراجل نيوتريشنست، يعني كبيدياتريك نيوتريشنست، من فضلكم ما ننساش خالص النيوتريشن بتاع الطفل. الطفل على ميكانيكال فنتيليشن، انت خايف من الاسبيرين، ديناميكال ستيبل كويس ومفيش مشاكل، نبتدي شيفت على طول للانترال فيدنج. وانس الجي اي تي بتاع الطفل ما فيهوش مشكله وانتكت، من فضلك انترال فيدنج وبروسيد في الانترال فيدنج، وما تخليش الولد مكمل على التي بي ان. صح يا دكتور احمد؟
Excellent question, especially patient. If the patient in the PICU, you should almost always concentrate on the nutrition and calories intake, because the patient, especially if the bedridden, the weakness can exacerbate it. The bedridden bed sores can be increased, and as well as the general condition of the patient can be worse if there is less caloric intake.
تمام. regarding ان احنا عندنا المشكله immunology problem، فاحنا بيبقى في some sort of nutritional recommendation ان احنا بنكون الهاي بروتين معانا. يعني لو احنا بندي البروتين ك بالانس دايت على مثلا 15، احنا ممكن نرفع ل 20 up to 25% من البروتين في مثل هذه الحالات. ولكن regarding ان احنا مونيتورنج لليوريا والكريات. don't raise your recommendation of protein without monitoring لليوريا والكريات، من فضلكم ما ننساش دي خالص. تمام دكتور احمد؟
تمام. I'm happy to be with you دكتور بهاء، دكتور عايدة، دكتور محمد هلال, and I'm very welcoming if you need me for any upcoming sessions.
ان
Just
شاء
let me
الله،
know.
لا ما تقلقش ان شاء الله.
More than
بعد
happy to be
رمضان
with you.
معاك ان شاء الله. ان شاء الله في السكند راوند بعد رمضان لا تقلق، احنا مش هنسيبك ما تقلقش. ده تشريف لنا طبعا يعني. احنا متشكرين لحضراتكم ومتشكرين حضوركم، ونرجو ان احنا نكون وصلنا كلير مسج. هاو تو بيك يور بيشنت، هو ده دور حضرتك كجنرال بيدياتريشن. الدكتور احمد لما اتفقنا نعمل المحاضره، احنا اتفقنا حضرتك تبيك اب، دونت ميس يور بيشنت. هيستوري ثم هيستوري ثم هيستوري up to 80% of diagnosis of such cases history. وكل اللي انا محتاجه منك دقيقه فقط، هتعمل الريفلكس وهتعمل السنسوري ليفل فقط. شكيت والله في اي حاجه في الهيستوري في الكلينيكال اكزامينيشن، وين يو داوت شاوت، يعني لما تشك اصرخ. هتصرخ على مين؟ هتصرخ على سب سبيشاليتي نورولوجيست ينزل يشوفه معاك تحوله. ده خلاص انت كده راجل كويس. ليه بنقول ونحدد ونعيد هذا الكلام؟ علشان يعني اطفال كتيره هتجيلك وهتدسمس ان انت هتقول اصله كان سخن من يومين، كان تعبان، اصل ده معلش احنا عندنا في مصر كده يجي يقول لك ايه ده الم نمو، مفاصله وجعاه فهو الواد بيلعب طول النهار في الم نمو. فانت لازم تبقى تعمل كاتروليزيشن للحاله بتاعتك وسمبليفيكيشن من خلال حاجتين اتنين: الهيستوري اكزامينيشن، حاجتين اتنين: الريفلكس والسنسوري ليفل. وكان الله بالسر عليم. مش بتاعتك بعد كده حكايه بقى اللي احنا خضنا فيها الاي في اي جي والموداليتيز والكلام ده. نيورولوجيست او لو حضرتك بيكيو هتبقى انت متمرس في المواضيع دي. احنا بس دورنا نعمل بيك اب بعد اذنك في الطوارئ او في عيادتك البرايفت كلينيك او في عياده الهوسبيتال بتاعتك كبرايمري سيرفي، تقدر حضرتك تعمله بعد اذنك. شكرا لحضراتكم وشكرا لوجودكم. انا بشكر استاذنا العزيز دكتور احمد صلاح الدين على وجوده وعلى اتاحه الفرصه